like to thank the organisers for asking me to speak on behalf of the Impact Steering Committee and collaborators on an update on interim data from our targeted screening in carriers of mutations in the BRCA1, BRCA2 and mismatched repair genes for prostate cancer screening. I'm Ros Eeles from the Institute of Cancer Research and the Royal Marsden NHS Foundation Trust in London. These are my disclosures. If we think about the risk of prostate cancer lifetime, 1 in 8 by the age of 80 or 1 in 6 by 90, it follows a normal distribution. So some individuals are at very much higher risk than the average of the population. And if we look at a single PSA screen, such as that done in the CAP study, there's no overall survival benefit. And of note, if you use a PSA threshold of greater than 3 nanograms per mil in this age group shown, about 1 in 10 people have to have a biopsy, but only 20% of the cancers are of aggressive nature, i.e. Gleason score greater than 6. And we need to remember this when we look at the data later from the IMPACT study. And the IMPACT study is showing increasingly that there's evidence that doing PSA screening in mutation carriers of BRCA1 and BRCA2 genes and mismatched repair does find aggressive disease. So this is the algorithm of the timeline of the IMPACT study, which started in 2005. And of note, this was before the MRI era. The quality of life component is embedded into it, particularly for the BRCA1 and 2 carriers. And then we added in a mismatch repair cohort in 2012. I'm going to show data today of the 4-year follow-up from the BRCA1 and 2 cohort and the baseline data from the Lynch cohort. And these results have been published. Firstly, from the interim results from the BRCA1 and 2 carriers in European Urology, and then the baseline data for the mismatched repair gene carriers in Lancet Oncology. This is the IMPACT network that was created internationally with data sharing agreements based on our previous consortia agreements. And these are the centres for the BRCA1 and 2 cohort. And the IMPACT aims are the same for both cohorts. We aimed to establish an international targeted prostate cancer screening study. It was PSA based because it's pre-MRI era. And our new studies now do embed MRI. And these were the power calculations needed for the BRCA cohort. It is an annual PSA algorithm. And of note, we do have biological samples taken, and the MRI is triggered in countries that now routinely do MRI as a result of a raised PSA. And although this is increasingly being adopted worldwide, most of the MRI data in IMPACT will come from Europe and the UK. This is the breakdown of the recruitment. Nearly 3,000 individuals, 65 centres in 20 countries, and the recruitment closed at the end of 2015. And these are the numbers of the BRCA1 and 2 mutation carriers and controls and BRCA2 mutation carriers and controls. Of note, the mutations had to be likely pathogenic or pathogenic, and the mutation non-carriers were those who tested negative for a mutation found in their family. Like many studies, the participants are mainly of higher qualification level and of European ethnicity. But interestingly, nearly 70% of them have no family history of prostate cancer. If we break down now the consort diagram in the European Urology paper, you can see here that for the BRCA2 mutation carriers, about 5.2% of them have an instance of cancer. There's a high positive predictive value of their biopsy, and that's compared with a 0.5 cancer incidence in non-carriers. So very much larger cancer incidence in the BRCA2 cohort in carriers versus non-carriers. And we see a much lower comparison in the BRCA1 carrier cohort. Now, this is the table from the paper, and I just want to highlight a few key points. So the first is, are we over biopsying these men? If we take a threshold of a PSA of over 3, and it was at that level because that was what the ethics committee would approve. And we're not having a high number of biopsies. When you compare this with the single PSA in the PSA population study shown at the beginning, it's 6 to 8%. When you look at the positive predictive value of PSA greater than 3 requiring action, then for BRCA2 carriers, it is nearly double that of controls. And the cancer incidence rate per 100 years for BRCA2 carriers is significantly different from that of controls, whereas you don't see this difference for BRCA1 as yet. Now, in IMPACT, the age range for entry was 40 to 69. So what we then did was an analysis to data age restricted from the ERSPC Göteborg data. And from this, you can see that the positive predictive value of biopsy and PSA was significantly higher in BRCA2 carriers versus what is seen in the Göteborg data. Now, what sort of cancers are we finding? Well, first of all, in the age ranges, we do see a younger onset in BRCA2 carriers of mutations, 61 years versus 64 as a median age at diagnosis. We also see a higher proportion of higher Gleason score and higher risk categories, and we do not see this difference statistically for BRCA1 as yet. So if we break this down, this is using the NICE guideline treatment data. We see that with BRCA2 mutation carriers that we have a high and intermediate need for treatment in 77% of those cancers that we're finding. So high proportion do need treatment. And if you look at the Gleason scores, you can see here for BRCA1 mutation carriers versus non-carriers, then we do not see any non-carriers with a Gleason score of 8 or above, whereas in BRCA2 mutation carriers, twice the number have Gleason score 8 or above compared with non-carriers. The Lynch cohort is much less well developed in terms of timeline, and this is the calculations here for the power calculations. This cohort is now closed. It is a smaller number of recruitment centres because fewer recruitment centres are managing Lynch patients, and PMS2 was excluded. So we only have data on MLH1, MSH2 and MSH6 mutation carriers as broken down here in the pie chart. Again, the mean age is low, 52.8, and it's the same type of demographic as we see with the BRCA cohort. And in the baseline paper published in Lancet Oncology, we have initial data on the proportion of mutation carriers that have clinically significant disease, defined as noted below this table. And we do not see any cancers as yet in MLH1 mutation carriers, but the cohort is not mature. So in summary, our interim results from the IMPACT studies show from these two papers that we would recommend yearly PSA screening in BRCA2 mutation carriers, and it is now an EAU guideline. We have submitted an application to the screening committee in England to include this as a guideline here also. And those with gene mutations are more likely to have aggressive disease. For example, with BRCA2, nearly twice the number that you see in BRCA2 non-carriers. And at the moment, we only have baseline data in Lynch syndrome and only see disease in MSH2 and MSH6 mutation carriers. But the proportions do look, again, high. And these individuals, therefore, would be recommended on NICE guidelines and international guidelines for radical treatment. What is not known is if you have very early disease, could they be managed by active surveillance? And early data suggests that maybe this would not be recommended, but we do need follow-up data to support that. We also need data on MRI going forward. So I would now like to acknowledge the steering committee and the collaborators, our funders, and I would like to show these names of our collaborators and those centres that took part to produce these data. Thank you.